Welcome. In this presentation, we'll discuss thought disorders that EMS providers commonly encounter. We'll define what thought disorders are and cover three major ones: schizophrenia, schizoaffective disorder, and delusional disorder. An important goal is learning to tell these apart from mood disorders, like depression or bipolar, and cognitive problems, like delirium or dementia. We'll then dive into practical EMS considerations: how to keep the scene safe, how to communicate and calm patients, and techniques for de escalation. We'll also touch on legal issues such as when a patient might need to be treated or transported against their will under an involuntary psychiatric hold. Throughout, I'll share real EMS field examples to connect this to real life scenarios. By the end, you should feel more confident in recognizing thought disorders and managing these calls safely and compassionately. First, let's clarify the term thought disorder. In psychiatry, this typically refers to psychotic disorders, conditions that involve a break from reality. In other words, the person's thoughts and perceptions are severely disrupted. They may experience delusions, which are fixed beliefs that are clearly false. For example, believing aliens are controlling them. They may also have hallucinations, seeing or hearing things that aren't there. A classic example is hearing voices when no one is around. We also see disorganized thinking. Their speech might be jumbled or hard to follow. These symptoms indicate the brain is not processing information normally. People with thought disorders often behave oddly or have impaired social interactions because their view of reality is distorted. They might also show a lack of emotional expression or motivation, what we call negative symptoms. For our purposes, the major thought disorders we'll focus on are schizophrenia, schizoaffective disorder, and delusional disorder. As EMS providers, recognizing these symptoms on scene can help us differentiate a psychiatric issue from other causes of altered behavior. Schizophrenia is probably the most well known thought disorder. It's a chronic brain disorder that usually begins in young adulthood. Patients experience episodes of psychosis, meaning they lose touch with reality. Classic symptoms include hallucinations, often hearing voices nobody else can hear, and delusions, fixed false beliefs like believing the TV is sending them secret messages. They might speak in word salad or jump between unrelated topics, making communication difficult. They can also have what's called negative symptoms, for example, showing very little emotion or neglecting their hygiene and daily activities. Schizophrenia affects about 1 in 100 people worldwide, so it's not extremely rare. Many live in the community and might occasionally become frequent flyers with EMS if their illness isn't well managed. One big challenge is that patients may stop taking their psychiatric medications, which often leads to a psychotic relapse. That's when we get called for bizarre or agitated behavior. It's worth noting that despite Hollywood portrayals, people with schizophrenia are usually not violent criminals. In fact, they're often more vulnerable to being victims than perpetrators. However, when someone is in a severe psychotic state, their behavior is unpredictable. They might be fearful or respond to hallucinated commands, which can pose a safety risk. As responders, we always approach such situations with caution and ensure scene safety, which we'll discuss more later. But the key point here: if you see a patient having hallucinations or delusions, schizophrenia is a prime consideration. Schizoaffective disorder can be thought of as a hybrid of schizophrenia and a mood disorder. In fact, the name literally breaks down to schizo, psychosis, and affective, mood or emotion. These patients experience psychotic symptoms like hallucinations or delusions, and they also have significant mood episodes, either mania, depression, or both. There are two major types: the bipolar type, where the person gets manic highs and often depressive lows too, along with psychosis, and the depressive type, where the psychosis comes with major depressive episodes. A key detail is that in schizoaffective disorder, the psychotic symptoms can sometimes occur on their own, even when the mood symptoms aren't active. That's what separates it from, say, a bipolar patient who only has hallucinations during a manic episode. What might this look like on scene? You could meet a patient who is clearly delusional or hallucinating, but also has an obvious mood component. Maybe they're extremely agitated, talkative, and haven't slept for days, which sounds like mania, and they're also telling you the CIA is monitoring their phone. Or perhaps a patient is very withdrawn, not eating or caring for themselves, signs of depression, and also reporting hearing voices. In practice, EMS management for schizoaffective patients isn't much different than for schizophrenia. Ensure safety, use de-escalation, and get them to care. But being aware of the mood element can help. For instance, a manic psychotic patient might be more impulsive or prone to grandiose behavior, whereas a depressed psychotic patient might be at higher risk of self-harm. We address whatever immediate behavior and threats are present. The diagnosis itself will be confirmed by hospital psychiatry. Our job is stabilizing and transporting safely. Delusional disorder is a bit different from the first two disorders. Here, the person has a fixed false belief, a delusion, But in most other respects, they function pretty normally. They aren't hallucinating voices, they aren't disorganized in their speech, and they aren't showing the broad range of symptoms that schizophrenia does. Their delusion typically lasts at least a month and can persist for years. A key feature is that these delusions often involve situations that could happen in real life, even though they're not actually happening. For example, a person might firmly believe that the FBI is surveilling them or that a neighbor is plotting to kill them. These things could be possible. We call them non bizarre delusions. But there's no evidence and it's just not true. In other cases, the delusion might be bizarre, like believing aliens replace their internal organs with someone else's organs, but that's less common in pure delusional disorder. We categorize delusions by theme. Persecutory delusions are very common. The classic paranoia that someone is out to get them. There are also grandiose delusions where the person believes they have some exceptional talent or fame, for instance, thinking they're secretly a world leader or have invented something monumental. Somatic delusions involve bodily functions or sensations, like believing they have a parasite infestation or a serious illness, despite medical evidence to the contrary. From an EMS perspective, these patients often come across as quite sane except for the fixed belief they're stuck on. You might get called to a scene and the patient calmly tells you, I need you to test my food for poison. My neighbor is trying to kill me. They might otherwise converse normally and have intact memory, etc. This can be challenging. If they're not a danger to themselves or others and they're refusing care, can you force them? We have to assess if the delusion is putting them or others at risk. If a person truly believes something like that, they might do something unsafe. For example, attack the perceived stalker or refuse all food. So we treat it seriously. Often these patients will need mental health evaluation, but since they often lack obvious signs of psychosis, we may need to use persuasion and involve law enforcement or mental health professionals to get them help. The main point, just because a patient is articulate and oriented doesn't always mean they're fine. A fixed delusion can be just as debilitating and dangerous as hallucinations, even if it's subtle. It's critical for EMS to distinguish a primary psychiatric thought disorder from other categories of illness, because the approach and underlying causes differ. Let's break down the differences. Thought disorders, psychotic disorders, like schizophrenia, primarily affect a person's thinking and perception. These patients are often alert and their attention memory might be okay, but what they're thinking and perceiving is not reality based. They might be fully awake and articulate, yet talking about things that don't exist. So the key here is a loss of touch with reality due to a psychiatric condition. They're not confused about where they are or who they are. Rather, they know those things, but overlay false beliefs or sensory experiences on top of reality. By contrast, mood disorders revolve around emotional state. For instance, someone with major depression or bipolar disorder. In a depressive episode, the person's primary issue is severe sadness, lack of energy, hopelessness, etc. In a manic episode, for bipolar, the issue is an excessively elevated or irritable mood, high energy, and impulsivity. Now, mood disorders can sometimes become so extreme that a person develops psychotic symptoms. For example, a deeply depressed person might start hearing a voice telling them they're worthless, or a manic person might believe they have godlike powers. However, these psychotic symptoms occur in the context of that mood extreme and usually match it. A depressed patient's delusions are often negative or nihilistic, while a manic patient's delusions are grand and optimistic. Importantly, if we treat the mood episode and it ends, the psychotic symptoms go away too. If someone has hallucinations or delusions without being in a manic or depressive state, then it's no longer just a mood disorder. It could be schizoaffective or schizophrenia. In the field, if you encounter a very euphoric, talkative patient who also seems psychotic, you might be dealing with a manic psychosis, bipolar with psychosis, or schizoaffective bipolar type. If you meet someone who is despondent and also responding to voices, think severe depression with psychosis versus schizoaffective depressive type. In either case, you'd manage initial safety and evaluation similarly. But it's good to note the mood component because, for example, suicidal risk is extremely high in depression with psychosis. Now, cognitive disorders are different from both. These include conditions like delirium and dementia, often referred to as organic mental status changes. Here, the brain's overall function is impaired, not just the content of thought. A delirious patient, say an elderly person with a bad UTI and sepsis, will have an acute change in mental status. They might be disoriented to time or place, have fluctuating levels of consciousness, maybe agitated one moment, drowsy the next, and impaired attention. They can absolutely have hallucinations or paranoid ideas, but the crucial difference is this results from a medical condition affecting the brain globally. Delirium is a medical emergency. It might be infection, low oxygen, low blood sugar, etc. Dementia, on the other hand, is a chronic process, like Alzheimer's disease, where memory and cognition deteriorate over months and years. These patients get gradually worse with forgetfulness, confusion, and eventually may not recognize people or places. They can sometimes develop delusions or misperceptions, but again, it's secondary to a degenerative brain condition. For EMS, distinguishing these matters because if you suspect delirium, acute medical cause of confusion, your priority is a medical workup, oxygen glucose check, transport to ED for evaluation. If you suspect primarily a psychotic disorder, like schizophrenia, you still need to ensure no medical issues, but the cause is likely psychiatric and the management leans towards calming, possibly psychiatric medications, or transport to a specialized facility. Vital signs can help. Abnormal vitals often point to medical causes, like fever, hypoxia, or unstable vitals are not typical in pure psychiatric illness. A known history helps too. An older patient with no psych history who suddenly is hallucinating likely has delirium until proven otherwise. In short, always keep an open mind. Is this psychiatric, medical, or both? Often it's not black and white, so do a thorough assessment. When responding to a psychiatric emergency, your number one priority is scene safety. This cannot be stressed enough. No matter how badly a patient needs help, you can't help them if you become a victim. So, if dispatch or your initial impression suggests the patient could be agitated or violent, don't rush in without ensuring you have support. If law enforcement is available, wait for them or call them in to stand by. It might feel strange to hang back, but taking a few moments to ensure safety is critical. Remember, safety before patient care. It's the same principle as with any scene, be it a fire, traffic accident, or psychiatric crisis. As you approach, maintain a safe distance. A good rule of thumb is to stay about 2 arms lengths away, approximately 6 feet. This gives the patient a sense of personal space so they don't feel threatened, and it gives you a buffer to react if they suddenly rush or try to hit you. Try not to let the patient get between you and your exit path. Always know how you would get out if things go south. And avoid turning your back on an agitated patient. If you need to retreat, do so facing them if possible. Keep your eyes on the patient's hands as much as possible. Many patients in a psych crisis won't be armed, but some might grab a kitchen knife, a piece of glass, or even improvised weapons. If you see anything like a weapon, retreat and get police to secure it. Also be mindful of environmental risks. For example, if you're in a small apartment cluttered with objects that could become projectiles, try to maneuver to a safer spot or gently ask if you can move to a quieter, emptier area to talk. Use personal protective equipment. Aside from the obvious blood or bodily fluid concerns, there's the possibility a combative patient could bite or spit. A face shield or goggles and gloves are wise if the patient is spitting or there's a risk of blood exposure. Some EMS crews wear body armor on any call that even hints at violence. This is becoming more common. That might not be an option everywhere, but be aware of your agency's policies. Work as a team. Decide beforehand who will be the one doing the talking. Often it's best if one person engages verbally while others hang back a bit. Too many people talking at once can overwhelm or confuse someone in crisis. If law enforcement is there, clarify roles. For instance, you might say, "We're going to try talking him down calmly. If he gets up and goes for the door, you intercept." Having a quick tack plan is just good practice. Finally, stay vigilant. Psychiatric calls can be very dynamic. A patient might be calm 1 minute and explode the next. Keep your spidey senses on high alert. Watch for signs of escalating agitation, clenching fists, pacing faster, voice getting louder. These can be red flags. If you sense the situation turning, be ready to act, whether that means backing off, calling for more help, or initiating restraints if absolutely necessary. Remember, you can't help the patient if you become a patient yourself. How we communicate with a person undergoing a psychotic episode can make a huge difference in the outcome. Our goal is to reduce their fear and anxiety, not add to it. First impressions count. Approach with a friendly but low-key demeanor. Imagine how you'd approach a scared child or a skittish animal. You want to appear non-threatening and kind. Introduce yourself by name and title. "Hi, my name is Megan and I'm a paramedic. I'm here to help." Do this even if they seem not to listen. It establishes who you are. Keep your voice calm and your tone caring. If you sound annoyed or aggressive, the patient will pick up on that and it can escalate their paranoia or fear. Speak in simple terms. In a crisis, a person's ability to process language may be impaired, especially if they're hearing voices at the same time. Short, direct statements work best, and be consistent. Avoid giving multiple commands or asking rapid-fire questions. For example, instead of bombarding them with, "What's your name? What's going on? Did you take any drugs? Can you come over here and sit down?" Pick the most important thing first and speak slowly. Active listening is a powerful tool. Often, patients feel extremely isolated by their symptoms. Imagine if you were hearing voices and everyone around you kept telling you it's not real or dismissing you. You'd feel misunderstood and probably frustrated or more agitated. So, even though we know the voices or delusions aren't real in a factual sense, the experience is very real to the patient. Acknowledging that shows empathy. You might say, I understand you're hearing voices right now. I'm not hearing them, but I believe that you are, and I want to help you. Or if they say something like, they're trying to poison me, you could respond, that sounds scary. Why do you feel that way? Inviting them to talk. Often just letting them vent a bit can reduce tension. While listening, use techniques like nodding and paraphrasing their statements. So you're feeling unsafe at home because you think your neighbors are after you, is that right? This kind of reflection, let me see if I understand you correctly, shows you're truly hearing them, which can build an alliance. Crucially, don't argue with their false beliefs. It's tempting to try to talk them out of a delusion logically, but that rarely works in the moment. The delusion is fixed. By definition, it's an unshakable belief. If you directly challenge it, there's no microchip in your brain, that's impossible. The patient will likely just get defensive or think you're in on some plot. Similarly, never mock or belittle the experience. Imagine if you were terrified and someone told you you're being silly, it's not going to calm you down. On the flip side, don't endorse the delusion either. You have to strike a balance. Acknowledge their feelings without agreeing to false facts. For instance, I understand you hear voices saying terrible things. That must be very upsetting. I don't hear those voices, but I know you do, and I want to help you find a way to get them to stop. This way, you're not confirming the reality of the voices, but you're not dismissing the person's experience. Also, coordinate your team's communication. One person should ideally do the talking. If the patient is hearing multiple people, plus possibly hallucinated voices, it just becomes a chaotic soundscape. Have your partner and others hold off on interjecting unless necessary. And if you need to convey info among yourselves, either step aside briefly or quietly signal. Don't start side conversations in front of the patient, as they might get paranoid that you're talking about them, which of course you might be, but it doesn't help them to see it. If you need to switch out who's talking, say the patient isn't responding well to person A, do it clearly. Okay, this is my partner. He's going to talk with you now. Is that okay? This keeps things transparent. Overall, treat the patient with the same dignity and respect as you would any patient. Use their name, ask them how you can help. They are human and likely going through one of the worst moments of their life. Compassion goes a long way. Verbal de-escalation is the art of talking someone down from a heightened state of agitation or aggression. As EMS, we often arrive after something has already triggered a crisis. So de-escalation is about reducing the intensity and preventing violence or self-harm. For a more in-depth discussion about de-escalation techniques, please refer to those lectures. For this lecture, let's quickly review some key techniques. Firstly, personal space is huge. We already mentioned keeping distance for safety, but it's also a de-escalation strategy because when people feel physically crowded, they tend to get more defensive. Watch your body language carefully. We communicate a lot non-verbally. If your arms are crossed, the patient might perceive you as closed off or disapproving. If you're fidgeting or appear tense, it could amplify their anxiety. Keep movements slow and deliberate. Avoid any quick reach towards them. They could interpret that as an attack. It's usually best to not touch a psychiatric patient unless you absolutely have to for safety or care, as touch can be misinterpreted or escalate things. And modulate your voice. Keep it low and calm. If they start yelling, resist the urge to yell back. Instead, you might actually quiet down, which often forces them to quiet to hear you, bringing the overall volume down. Finding common ground, or at least acknowledging their grievances, can be a turning point. Many times, an agitated person feels that no one is listening or on their side. Use phrases that show you get it. For instance, if a patient is shouting, "Leave me alone, I don't want to go to the hospital," you can respond, "You don't want to go to the hospital. I hear you. I understand you just want to stay here." That doesn't mean you're ultimately going to leave them there if they're not safe, but at least you're showing you respect their wishes. Offering choices is a classic de-escalation move. When a person feels out of control, giving them some agency in small ways can reduce their need to resist. Make sure any options you offer are ones you can live with. Don't promise something unsafe or impossible. When necessary, set gentle limits. This is tricky because you don't want to come off as threatening. It's about stating consequences in a non-personal, factual way. Like, I want to help you, but I can't do that if you're swinging at me. I need you to keep your hands to yourself. Or if they're trying to run, if you run away, I'm worried you might get hurt or the police might have to chase you. I don't want that to happen. You're framing it as cause and effect, not as a punishment. And you always reiterate that your goal, and hopefully theirs, is that nobody gets hurt. Time is your friend in many of these situations. Unless the patient has an immediately life threatening medical issue, spending extra minutes on scene to talk someone down can prevent an hours long physical struggle or even injuries. Obviously, if the patient is in medical crisis, like excited delirium or something, we can't just chat for an hour. But most pure psychiatric emergencies allow some time for verbal strategies. However, we must also acknowledge there are times when verbal techniques fail. If a patient suddenly charges at you or others or starts self harming seriously, you may have to use restraints or chemical sedation for everyone's safety. Always try verbal de escalation first, but have a backup plan. This means ensuring you have enough manpower. Trying to safely restrain a violent patient with just two providers is dangerous. Ideally, have police or multiple responders to assist. Chemical restraint, like giving a sedative or antipsychotic injection, might be an option if you're trained and allowed to as a paramedic, but again, that's typically guided by protocols and sometimes requires medical control orders. The key is if you see the patient is about to harm someone and talking isn't working, be decisive and swift in enacting restraints. It should be done as humanely as possible. Talk the patient through it. I'm sorry, we have to hold you because we want everyone to be safe. Once restrained, ensure their airway and circulation are okay and continue to speak calmly. I know this is uncomfortable. We're going to take care of you. Document thoroughly why restraints were necessary. In summary, verbal de escalation is often our best tool to avoid using force. It's a skill that improves with practice. Observe crisis negotiators or mental health professionals if you get the chance. They often use these same techniques. And always debrief later on what worked or didn't to keep learning. Mental health emergencies live at the intersection of medicine and law. As EMS providers, we have to be mindful of a patient's rights, but also public safety and our duty to care. So, what do you do if a patient with a thought disorder doesn't want help? Each state has laws that allow for an individual to be taken for a mental health evaluation against their will if certain criteria are met. These criteria universally include the person is a danger to themselves, for example, actively suicidal or engaging in self harm, a danger to others, making credible threats to harm people, or so psychotic that they could unintentionally hurt someone, or is gravely disabled, meaning due to mental illness, they cannot provide for their basic needs for safety, food, shelter, etc. Gravely disabled is a bit subjective, but it covers situations like a person who is wandering in traffic or not eating because of their delusions. In plain terms, if you reasonably believe the patient's mental state is putting them or others in imminent danger, that's when an involuntary hold is justified. Now, who can actually initiate that hold? That depends on local law. Many places require a police officer or a licensed mental health professional, like a psychologist, psychiatrist, or designated crisis worker, to formally sign the paperwork. Paramedics in most places do not have the independent authority to legally commit someone. However, some regions have started to allow certain EMS personnel to initiate holds if they've had extra training. Always know the rules in your area. In practice, what this means is if you have a violent or at risk psychiatric patient who refuses transport, you'll likely be calling law enforcement to come and do the official sectioning, or at least to be there to ensure the patient goes. But there's also the concept of medical implied consent. If a patient is so mentally impaired that they can't grasp the consequences of refusing care, from a medical perspective, you're often allowed to treat them as if they are unconscious. For instance, someone who is psychotic and says, "No hospital, I'm the president and I have to stay here to command the army of squirrels." That person is not making an informed, rational decision about their health. We treat that similar to a confused post seizure patient who refuses. They lack capacity, so we act in their best interest. That gives you some legal cover to initiate assessment, treatment, transport, even if the patient is saying no, provided you document why you believe they can't decide for themselves. However, just because we have that right doesn't mean we use it heavy handedly. We prefer cooperation and persuasion whenever possible. But if it's clear the patient meets the hold criteria, don't just leave them because they said no. That could be a bigger liability, abandoning a patient who is a danger. Instead, involve law enforcement, explain the situation, and do what you can to get the patient to the hospital safely. When it comes to restraining a patient or treating them against their will, always follow your protocols. Use the minimum force necessary. For example, if a patient will walk to the stretcher, you don't need to hog tie them. Maybe just having police present is enough of a show of authority that they comply. Physical restraints, soft restraints on a stretcher, should be used if the patient is a clear risk of hitting, kicking, or running off and into danger. Chemical restraint, such as a sedative, might be an option via medical control if the agitation is severe. Remember, as soon as you restrain someone, their well being is 100% your responsibility. Never leave a restrained patient alone. Monitor their airway, circulation, etc., because things like positional asphyxia or medical issues can happen. Working with law enforcement is important here. Ideally, you both agree this person needs to go involuntarily. Sometimes officers might say, hey, they seem fine to me if the patient calmed a bit. This is where your documentation of what was said or done earlier is useful to justify why you still think they aren't safe. Also, clarify roles. Once you start transport, in many places, the hold becomes a medical hold under the receiving hospital's authority. Police might hand you a form, or you might have to sign something at the ER that transfers custody. And yes, paperwork, not fun, but vital. Document everything. The exact quotes from the patient that indicated psychosis or risk. Patient stated he has a gun and will shoot if aliens come. The fact that you explained the need for evaluation and what their response was. Patient unable to process information, shouting about aliens instead of answering questions. Any involvement of police, include officer name or badge and that they executed a hold if they did, and what interventions you did for safety. If you sedated the patient, document the time, drug, dose, and effect. If you restrained them, note position, secured supine on stretcher with soft restraints to wrists and ankles. And that PMS, pulses, movement, sensation, was checked on all extremities. This documentation not only protects you legally, showing you acted within appropriate guidelines, but also helps the receiving facility understand what happened before arrival. The psych doctors will appreciate knowing the context. In summary, from a legal standpoint, don't be afraid to act when someone truly needs help and is endangering themselves or others, but always act within your scope and in collaboration with law enforcement or medical control as needed. Know your local laws and follow protocol. At the end of the day, our job is to protect life, and the law is generally on our side when we do so in good faith under the right criteria. We will wrap up thought disorders here. Please join me in the next lecture to apply what we have learned to a patient you may encounter in the field. See you then.